everybody. My name's Leigh Ann O'Banion. I'm a vascular surgeon at UCSF in Fresno, and I'm here tonight with Dr. Paul Foley. He is the director of the vascular lab at Doylestown Hospital, and he's also an adjunct associate professor of surgery at the Hospital of the University of Pennsylvania. He really just wanted me to say, hey, this is Paul, but I felt like he deserved the introduction. We will be joined momentarily by Dr. Mazin Foteh, but he's attending to some clinical business first. First things first, I would love it if everybody just kind of put who you are and where you're from in the chat. We want to know, kind of what specialty you're in or what your profession is, and where you're from. This is an open-ended discussion. We want this to be interactive, and so please feel free to put any questions. We will pause for discussion when it's appropriate. We're really excited to make this interactive. These cases have been pre-recorded, but they are designed to kind of pause and stop and go through these cases step by step. And then as Jen put in the chat, please click on everyone when you write in the chat so that we can all see what you guys have to say. So without further ado, I'm going to turn it over to Dr. Foley, who's going to start us off with the case.
All right, great. Thanks, Leigh Ann. So my name is Paul Foley. I'm a vascular surgeon, like Leigh Ann said, in Doylestown, which is about 30 miles north of Philadelphia. I'm going to start the video. As she said, it's a pre-recorded video. I'm going to turn the audio down and just sort of narrate over the top of it, but hopefully it'll stimulate some discussion. The case is a really nice case of a gentleman who has limb-threatening ischemia, but the lesion characteristics and then what we were able to accomplish with Javelin over a very focal lesion is really quite impressive. I think you'll see it at the end. So what we'll do here is give a little bit of background, and this is going to be somewhat bizarre because it's going to be me narrating a narration of myself, which is a very unusual experience that I've never had before. But the patient is an 83-year-old, 84-year-old male who presented with limb-threatening ischemia that was manifested by a non-healing hallux ulcer on his left foot. Very, very advanced comorbidities, heart failure, and then the usual suspects that make you think of calcified arterial disease. He had a preoperative evaluation in the vascular lab that showed non-compressible ABIs bilaterally, and on the left, his TBI was severely reduced at 0.3. So automatically, we're sort of thinking that this is calcified arterial disease, but we also had duplex information demonstrating that he had normal velocities from the common femoral through the popliteal with no evidence of any significant stenosis. So for this distribution of disease, I like to attack this from an antegrade approach. So we chose beforehand, knowing that there was no SFA pop disease, that we would approach this from an antegrade femoral stick on the left.
So Paul, I'm going to have you stop right there, because let's talk a little bit about this, especially when you're dealing with heavily calcified occlusive disease. I think you made a really important point, and you clearly trust your RVTs, you trust your techs. They do really good duplexes. I couldn't agree more that I think when you're dealing with tibial disease, that an antegrade approach is almost essential to maximizing your crossability and your pushability. But how do you prep these patients? Are you prepping the foot in? Are you anticipating potentially needing pedal access? When do you get a CTA? How do you kind of do that preoperative planning to ensure that you maximize yourself for success?
Yeah, so vascular lab always, obviously, physical exam is an important component of this as well. And so for me, if a patient has weakly or non-palpable femoral pulses in the office, or any duplex information suggesting that they have either common femoral disease or aortoiliac disease, they get a CTA automatically in my evaluation. And if I'm going to get a CTA of the abdomen and pelvis, I'm always doing a runoff as well. So those people almost always get a CTA of the abdomen, pelvis, and then bilateral lower extremity runoff. If they have a strongly palpable femoral pulse, as he did in this particular case, and then the duplex information suggests that there's infrapopliteal or small vessel disease, I do approach that from an antegrade approach, but I always talk to the patient and have it ready to go, that I may have to access the foot. And I always talk to them about that beforehand as well. For me, what I do is just make sure the foot underneath the angio drape is available for access. So what I do is if I ever need to do, it's, their foot is sort of laid out on a towel on the bed, but then if I need to, I just cut a little hole in the drape, tegader, or prep the foot, and then kind of tegader where I need to, and then access that way. And I find that that's probably the easiest way for me to do it because I don't oftentimes need to access retrograde pedal.
No, that's great.
I just find that you're right. When you're approaching these things and you really put a lot of thought into how you're going to approach it, it really sets you up for success. And for these cases, it's so challenging technically to begin with. You want to give yourself every advantage possible. And I apologize. I really floroed the general surgery resident's hand quite a bit here, but such is life. So the other thing I should point out is for antegrade access, I don't hesitate whatsoever to stick like right at the SFA origin. I find that that's easier a lot of times. I find that sometimes I struggle a lot with sticking the common femoral artery and getting the wire where I want it to go. So I'll try to, under ultrasound, just sort of stick right at the femoral bifurcation or right at the origin of the SFA and then go in that way. So in
So
this particular,
I'll kind of pause just for a second, just because Dr. Mazin Foteh has joined the room. So I'll take a brief moment just to introduce him. He's the director of the Aortic Therapy and Innovation and the co-director of the Aortic Clinic at Baylor Scott and White Heart Hospital, Plano. So let's welcome him to the session. And Mazin, just to catch you up, we were talking about preoperative case planning and, when you determine, do you go antegrade routinely? Do you get preoperative CTAs? How do you determine to optimize your case planning, especially when you know that you're dealing with heavily calcified occlusive disease? So I don't know if you want to weigh in before Paul continues on with the case.
Yeah, so that's a great question, Leigh Ann, and I'll tell you, most of the people that show up at our facility are actually outpatients who come in through the ER. So pretty much everybody is going to have a CTA prior to us even being consulted, and based on that CTA, that allows us to create a perioperative plan, whether that's retrograde access, antegrade access, tibial access, or all three if needed. Probably very similar to your approaches, and it looks like we got a good case underway. So I'd love to hear more about what Dr. Foley did in this case.
All right, let's go.
all right, so we did an original shot here showing, as suspected, that there was no significant disease in the SFA or the popliteal artery. We go down kind of one segment further, and coming into view here, you can already see on the unsubtracted views that there's calcified arterial disease here showing up on the fluoroscopy. So we're about ready to shoot the infrapopliteal segment here. And basically what we're going to find is some pretty awful multi-level, multi-tibial arterial disease. So popliteal artery is open, the tibio-perineal trunk is open. There's a focal stenosis, which is somewhat difficult to see right in the proximal perineal artery there. The anterior tibial artery is patent for a stump, and then it occludes into a collateral. And then the posterior tibial artery has segmental occlusive disease all the way down. And as you'll see on the next film, there's a rock pile of calcium near the ankle, which is occluded. And then there's very limited reconstitution out into the foot. But to me, remember, this patient is elderly, multiple comorbidities, has tissue loss with a non-healing hallux ulcer, and we're going to be very aggressive about intervening here. So you can see the outline of the posterior tibial artery starting at the mid-calf, going all the way down to the ankle. And what you'll see here is that that's completely occluded with very limited reconstitution into the foot. The anterior tibial artery really does not come back. The dorsalis pedis artery really does not come back. So what we're dealing with here is single vessel perineal with some flow into the foot, but you're up against a significant challenge here trying to get this to heal. But I do think obviously that there's value while you're here, even just to bridge the patient if you're deciding to do something else, if that's appropriate for the patient as the next step, but treating the disease that you can while you're here. So
Well, and I think too, Paul, like just to jump in here for now that we've seen the angiogram, this is the point where you kind of start your treatment algorithm. And I've already watched your case. I know it's going to be amazing, but just to kind of walk people through, like at this point, you say, okay, everything's normal to below the knee. What am I going to do to maximize my success here? Because I can see even from this small computer screen that I'm looking on that you have actually a focal perineal occlusion. I mean, that looks pretty bad. I think what you're seeing is a collateral come off the side. So, and clearly with the lack of runoff in the foot, that's a significant hemodynamic occlusion because you're not getting any significant runoff and you don't even know. I mean, I personally like to think that usually there's just some hibernating vessels in the foot. Maybe that's my eternal optimism for these patients. But what do you do? Are you going to put a long 5 French sheath in? What wires are you going to choose? What's kind of your go-to treatment strategy when you see this?
Yeah, so when I look at this, I'm going to be aggressive. I usually try for the easiest thing first because that way I can, have some element of success here. So for this patient, if you wanted to try to tackle that posterior tibial artery, certainly it's an option. The anterior tibial, I look at that and I probably wouldn't even try necessarily because it didn't really have anything that reconstituted. You could poke at it if you want, but my algorithm is try for the easiest things first, so at least you have some element of success, and then you can attack some of the more difficult things as the next step. As part of what I do here, when I kind of play this through, is if I know I'm going to go after something below the knee immediately, I upsize to a longer sheet. So I've got a Benson wire or a Stork wire, some sort of stiffer wire down further in the popliteal. We have this really nice setup in our room. Antegrade access can be a real pain in the ass. And if you don't have a good setup, wires going in and out, catheters going in and out, sheets going in and out sometimes. I always find that it's very hard to get that sort of technical stability in the catheter and the wire setup. So we've just taken, and this is not like, earth shattering, but we've just taken our long angio table, we bring it across the body, sort of perpendicular to the length of the body, and then we run it across that way. But this is me putting in our 5 French 45, 5 French 55 centimeter sheath, and I park that in the popliteal artery just to get as much support as I can. And then my typical approach for this is to bring an 035 system down sort of into the origin of whatever tibial I'm going to deal with, because I find that with a quick cross and a glide wire, which is my typical setup, I can select the tibial I want to and then transition over to an 014 platform at that point. So what is that kind of similar to what you guys do or your approach, or do you guys do something totally different?
Yeah, Mazin, why don't you go through your kind of what you would do in this case, in terms of, and I would just like to point out because the voiceover on this video is muted. I'm going to give you kudos, Paul, for letting your general surgery resident cross this perineal lesion because that's some great teaching right there. But no, Mazin, I'd love to hear kind of what's your wire escalation
or
technique?
stupidity,
What do you use to cross?
Yeah, so in a former life, much of the way I approached these complex cases was to sort of use a increasing telescoping technique of various sheets, catheters, and wires to cross these lesions. Similar to Dr. Foley's approach here, I would bury the 6 French or 5 French sheath into the distal vasculature below the knee, work with an 035 catheter of some sort, and then probably telescope with a smaller 014 platform to try to cross these lesions. Most of the wires that I would use were probably more navigational in nature. And if those failed, generally I would increase my selection to something that was weighted. For instance, like a Treasure 12 wire to cross the lesion. If that didn't work, obviously the wire of last resort for everybody is probably an Estado, something along those lines. And if that failed, then I would be thinking about possibly doing transpedal or transtibial access to retrograde crosses. That's sort of some of the techniques that you guys utilize.
Yeah, I mean, I think so. I have a pretty low threshold to poke the foot, although in this case, you don't really know what you're working with. So I think you have to maximize your chances to cross from above. But I think giving yourself as you said, like a good platform and a rigid platform to be able to cross kind of maximizes your chance at success. I forget what webinar we were or forum we were talking about the other day, but someone told me to try the Mongo wire, and that has become like one of my new favorite wires.
Okay.
I started using that, the 014 wire, and it's great. It's fabulous. So that's been my new favorite toy in terms of crossing some of these difficult lesions.
Yeah, agree. Mongo wire is great. Um,
Maybe it was you, Paul.
I got that from JD Coral though. So I stole it from like the interventional cardiologist. I'm not smart enough to know those kinds of wires. Although I will say that we share our hybrid space with the interventional cardiologist. So every once in a while we have some texts that go back and forth, and I cheat a little bit and ask them, well, what wire would the cardiologist use to get across some of these small things, and then pretend like I know, and I'll say, oh yeah, give me that. So
I think I just, sorry to interrupt you again, but I do think that's
that's
such an
fine.
important topic to bring up because I think we all learn so much from each other. And we don't talk about enough how much it's important for vascular and interventional radiology and cardiology to work and learn from each other. Because while we all view things a little bit different, we all bring a different mindset to the table. And I have learned so much from my cardiology and interventional radiology colleagues. To everyone that's listening, get yourself to a multidisciplinary conference, explore outside of your specialty, because I think it really like enhances your skill set and kind of what you bring to the table when you explore outside of your own specialty. Just my 2 cents.
So it
No,
looks
I
like you
totally agree.
crossed here with that same quick cross catheter.
I did. I had a 035 glide and a quick cross, and was able to sort of push across that focal perineal stenosis or focal occlusion in the perineal artery. And then this is our subsequent arteriogram, just to confirm that we're in the true lumen and haven't created any vessel trauma after doing that. So our workhorse 014 wire is a Hydro ST, which I think is a Cook wire. So that's what we're setting up to go down with next here. So that gets advanced down through. Now, I look at this, and to get back to Leigh Ann's point about what's your algorithm for treating disease like this, well, I can tell it's calcified on the unsubtracted images. I put an 014 wire down. I already know and have a suspicion for this based off preoperative characteristics and his AVI being non-compressible, that I'm going to need to modify something with lithotripsy. But I've confirmed that now on the arteriogram. And then to follow that up, I want to have a really good understanding of what I'm dealing with. So we're going to come out with the quick cross catheter, and we're going to get set up with an IVUS interrogation of that lesion, which I think is profoundly important to really understand your lesion characteristics. And you can tell a lot off of the intravascular ultrasound images above and beyond what you can get off the arteriogram. But sizing is very important, and certainly not only just for Javelin, but sizing's not as important for Javelin, I should say, but sizing's incredibly important for balloon-based IVL. And so I know that the focus of this case is on Javelin, but I think it's important to highlight that as well. So you can see going down with the IVUS catheter, there's diffuse calcification through the kind of whole length of the TP trunk and proximal perineal, and then we're going across the lesion right now with the IVUS probe, measuring diameters proximal and distal to that lesion, but it's very heavily calcified, and the lumen around the IVUS catheter tip was almost obliterated. So I know, and I'm confirming now, that this is something I want to treat with IVL. The
So,
decision then, yeah,
so
go ahead.
Paul,
Sorry.
let's talk a little bit about, how has IVUS changed your practice pattern? And when you see something like this, and Mazin, you weigh in too, it looks like your vessel measured anywhere between 2.7 to 3.1.
Yeah.
Whether you're going to use Javelin or you're going to use E8, when you're thinking about the size of your definitive therapy that you're aiming to use, how does that IVUS picture, and then and when you're using IVL technology, influence your sizing of your balloon?
Well, for sizing of the IVL balloon, I think it really gives you a very accurate understanding of what the target vessel diameter is, right? And then you can kind of move forward with oversizing by 10%. And I think for many of us who do IVL quite frequently, we've gotten very comfortable at following that 10% oversizing without any vessel trauma. But what it also allows you to do in the case of Javelin here is really localize your lesion relative to your radiographic landmarks, but also understanding what you're dealing with in terms of your plaque characteristics, really have a good understanding of where the calcium is. Is there luminal calcium? Is it confined to the wall of the blood vessel? And then doing, after you've finished with Javelin, in this particular case, having an idea of what you want to do for your balloon sizing so that you're not overly aggressive with your post angioplasty that may result in some degree of vessel trauma. So I just kind of try to keep that as one-to-one as possible following lithotripsy delivery with Javelin.
Yeah, my strategy, I would say, is pretty similar to that as well. I think just like the whole point of this is that we're pretty terrible at estimating the size of vessels based on angiography alone, and we have to be utilizing intraluminal imaging, such as IVUS or OCT, to get a better understanding of how large these blood vessels actually are. Once you find yourself, sort of working in the PAD space and getting into CLTI, you quickly learn that you early in your practice will treat with undersized balloons, and then figure out quite quickly that you have to upsize and treat appropriately. So I applaud you for number one, using IVUS and taking the time to do that, but also two, being true to this patient and definitely treating with an appropriate size balloon and catheter.
Yeah, and Dr. Bernstein on here said that he uses IVUS for every case. But for any of you that aren't paying attention to the chat, go ahead and toss in, do you use IVUS? Do you not use IVUS? We can make the chat a little interactive while Dr. Foley continues with the case. But as he continues, I just want everybody to notice as the IVUS rolls through, you can see the circumferential calcium, you can see the occlusion, but what you don't notice is a ton of pulsatility through this vessel. This is really that medial arterial calcification and that lead pipe morphology that we see that can be so challenging to treat.
And this is a perfect example of what you guys were just talking about. I mean, I would go through this and I would look at the arteriogram and say a TP trunk that's 4.5 or 4.7, I would never sort of think to write, and you look at our arteriogram and I was always like, oh, TP trunk's like 3.5, maybe 4. But, what you realize is that, like you had said before, we're inaccurately sizing balloons. All right, so this is the setup. And I think for those of you who have not used Javelin or have sort of a limited use of it so far, this setup is very straightforward, but once you kind of get the hang of it, it's very easy on the back table. But the Javelin catheter is a very easy setup. The wire port on the back gets flushed through with saline. Then there's a single chamber that is an inlet port on the side, as you can see there where Mike's finger was pointing to. Goes all the way through the IVL chamber at the tip and then all the way back out through the outlet port. So when you're prepping the device on the back table, there's a stopcock that gets hooked up to the outlet port, and on the inlet port, you hook up the end deflator. And essentially what you're doing is flushing through saline. There's no contrast with the Javelin catheter. It's only saline, and we're flushing through at about 4 to 6 atmospheres until you see the saline dripping through on the side. You flush it through, you see the saline coming out the other side. Once you've reached that point, you close the stopcock and you're ready to load it up on the wire. So it's a very, very straightforward setup. The generator hookup is exactly the same as what you would do for the balloon catheters. So once you have that accomplished, the Javelin catheter gets hooked up, gets loaded onto the 014 wire, and it's put into position. And this is a nice way to sort of get everybody involved on the team here, because the setup, along with the device delivery and then the pulse delivery, is sort of a team approach, as you can see here. So really having people engaged and involved in the process, I think, is very, very important as well. So that's just kind of finishing up here with the prep. The stopcock is closed, and now we're ready to go loading this up. So the general surgery resident here is advancing the Javelin catheter down over the 014 wire, and we're just going to bring that just proximal to where the focal perineal lesion is. So there's two things to keep in mind with this Javelin catheter. One is crossing the lesion, and the second thing is pulse delivery. So you're simultaneously accomplishing two things. Now, for this particular lesion, you can be very selective and very precise about how you want to deliver your pulses because you have 120 pulses to deliver into a very focal lesion. But to look at this in a different way, if you were to use a different device, now S4 is going away, but E8 would seem to me to be very much overkill, although Leigh Ann has sort of an interesting point to make about that in a second. But for me, I look at this and I say Javelin's a perfect device in this particular case because it's a very focal, calcified, isolated lesion that I can be very precise in terms of my energy delivery with the Javelin catheter. So now that this is hooked up,
Well, and
we're gonna,
Paul, the other
yeah.
thing, this is your case, so I'd like to hear like, the peanut gallery with Mazin. Are you thinking when you're pulling this javelin, like, okay, I have this short lesion, maybe I already know I can cross it with my crossing catheter. So I'm not really
Right.
using javelin to cross per se. So I'm probably only going to use maybe like 3 to 4 pulse cycles on this short lesion. Am I pulling javelin because I think maybe I'm going to go after one of those two other tibial vessels that are going to be much more challenging to treat? Or are you just pulling it saying, I really just need a short, focused delivery energy?
So yeah, that's a great question because that's exactly my thought going into this was I was going to use a limited number of pulses for the perineal lesion, which we did. We did not use all 120 pulses here. And then I was going to go out and deal with the posterior tibial artery next. So what we did after we finished with the perineal in this particular case was wire the posterior tibial artery. However, it was so densely calcified down near the ankle, I could not cross with a wire. And my algorithm with Javelin is that if I can't cross it with a wire, I'm not going to try Javelin.
Well, and I think it's a
Yeah.
really important point too to note that javelin is not it's not a miracle crossing catheter. We're all vascular surgeons here on this call, and so when we open a vessel that's occluded, you see why you can't cross a lesion. And so I think it's unrealistic to think that javelin's going to work 100% of the time. And you have to take the IDE trials and the randomized controlled trials with a little bit of a grain of salt because that's looking at safety and efficacy. But the real world application, when you're pushing the limits in the most difficult of lesions, I kind of like, I used to play softball. So I kind of think about this in terms of like your batting average. And if you think of CLTI patients, if Javelin allows you to cross 30 to 40% of the time, when otherwise that patient was a no option patient that would have gotten an amputation, we're making huge strides in the treatment of limb salvage. So that's just kind of my thoughts on like, application of Javelin.
To get back to the controversy between using Javelin versus E8, and just playing devil's advocate, to me, this is an excellent E8 case all day long. You've already crossed, you've got an 035 catheter across it. E8 has such a wonderful crossing profile. You don't have to pre-dilate anymore. It'll go through that entire lesion very easily. And if the goal is to deliver energy, to deliver, pulse waves, my impression would be to proceed with E8, but I'm excited. I have not seen this case, and I definitely want to see what the outcome is going to be.
All right, great. So I'll keep going here. So what I'm doing here is basically, I know I'm getting across. I've already sort of inched across it. That was never a concern, as you correctly pointed out, being able to cross this with an 035 quick cross, which has a very similar crossing profile. But I have this javelin parked right in the middle of the lesion, and then I'm just sort of manipulating it. I'm not moving it at all. I'm just delivering energy into the calcified lesion here and sort of doing micro movements back and forth in between. You get 10 pulses. So there's 12 sets of 10 pulses for 120 pulses. In between each cycle of 10, you flush the system through by opening the stopcock, inflating the end deflator to 6 atmospheres, no higher than 6, or you risk rupturing the IVL window. Once you get to 6, you close the stopcock and it sort of drifts back down somewhere between 4 and 6, and then you're ready to go to deliver your next set of pulses. So there is a little bit of work to do in between each set of pulse delivery, but once you get into a routine, it's actually very straightforward. So we've delivered, we've crossed. Now I'm sort of gilding the lily here, but I've been able to very easily deliver several rounds of pulses across this lesion, and clearly I'm getting across here. So we take the javelin out over the wire, and with the intent of using additional pulses somewhere else, but that did not come to fruition in this case. So now we're putting the IVUS catheter back down, and I think this is where Leigh Ann wants to make a really nice point, which I'll let her do. But what I'd like to highlight here is keep in mind there is no balloon angioplasty component to javelin. This is simply energy delivery focally placed into the target lesion. And what we're going to see here is a dramatic improvement with luminal gain and calcium modification just with energy alone through that previously almost obliterated lumen. So this is what we were left with here. And Leigh Ann, I know you wanted to make a point here, so I'll let you go ahead and do it.
It's so beautiful. Like you're just sitting on it, and the pulsatility in that vessel is really remarkable. And not to, jump on the E8 bandwagon, because I do think that you can clearly see here the advantage of Javelin in terms of just getting luminal gain in a short focus lesion. But in my mind, like I see this circumferential medial arterial calcification. It's a long segment, this whole artery is a lead pipe. And I see what the pulsatility and compliance change that you've been able to get utilizing the IVL technology in this lesion. And I just wonder, if you treat with E8, it's low pressure, it's safe. Are you going to change the compliance of that whole TP trunk and perineal? Are you going to improve that pulsatile inflow into the foot? So like Mazin was saying earlier, this might have been a case, and even more convincing now that I've watched what you've done and how you've changed the compliance of the vessel, that maybe I'm more likely to pull an E8 even when it's a short focal lesion, knowing that I'm wanting to change the compliance of the entire vessel, not just that short lesion. I don't have any evidence to prove that. It's just kind of my observation.
Dr. Foley, is this image here just with E8 alone, no balloon angioplasty?
Just with Javelin alone. So no
Javelin. Sorry, I apologize.
This is,
Javelin alone.
No, that's okay. So Javelin alone, the IVUS was post-Javelin, and now this is the post-Javelin arteriogram with no angioplasty at all. So this is just right after we've done simply IVL with energy delivery, which is a dramatic improvement just with energy delivery alone, which I think is outstanding. So then my standard treatment here is to follow this with one-to-one sizing as best you can. Now, granted, there was a pretty significant size difference across this, so we split the difference, and we're using a 3.5 angioplasty balloon across this lesion. I inflate that to nominal pressure. And then for all of these tibial lesions, I don't know what you guys do, but I've really gone to longer inflation times, almost at like a nominal to subnominal balloon inflation. So that's our 3.5 by 4 that you can see there. And I hold these inflations in place for usually about 3 or 4 minutes. Sometimes I get impatient and I can't last or stand it for that long. And then just sort of slowly deflate it back down and remove it over the wire. But that's my standard kind of balloon inflation technique. I realize I don't have a lot of other than anecdotal support for that. But what do you guys do?
Yeah, I think I take a similar approach. I think I've developed a lot more patience when it comes to these types of lesions over time, and I tend to inflate with lower pressures, subnominal pressures for longer, just like you've described, and I've definitely seen the benefits of that for sure. In this scenario, a drug-coated balloon is not an option, obviously, because it's a little too small for something like that. But I think the result that you got here was excellent, quite good, and very impressed with what I'm seeing.
Yeah, and I mean the nice thing is we have all these tools in our toolbox now. So you post IVUS this, it doesn't look perfect. You can throw in a bioabsorbable scaffold. But for the most part on IVUS, this looks great. I mean, there's no dissection, there's no recoil stenosis. And you've given the patient a really impressive result. So congratulations, it's a great case.
Yeah, it turned out very well, and I think it just highlights what you can accomplish, and it really speaks to the mechanism of IVL being able to modify these really challenging lesions. So yeah, thank you.
Fantastic. Well, if there's once again, if there's any questions, feel free to put them in the chat. But if not, I think we'll have Dr. Foteh share his screen. And we're going to shift gears a little bit towards E8, recognizing the complementary nature that I think Javelin and E8 play. I think they're both devices that you need to have in your toolbox. You can't have one without the other. I think they both play such a complementary role. But he's going to be discussing a case of multi-level high-grade stenosis.
Thanks, guys, and once again, thank you for having me here. Thanks for Shockwave for putting this this webinar on. I'm certainly excited to be here, and I want to present my my case. Hopefully, it's just as exciting as Dr. Foley's case, but I'm a huge E8 fan, so I'd love to get their input on what they think here. And I may actually go ahead and
So we're just going to go. Oh, sorry, I forgot to tell you. I threw you under the bus there. We're going to go on mute and just let
okay.
you narrate the case. So you're going to have
Oh,
to watch
perfect.
yourself talk and then just talk over it.
Okay, perfect. So just to give you guys some background, this was a 79-year-old man who showed up with multivessel high-grade stenosis, non-healing wound of the first digit, has a history of coronary disease, hypertension, hyperlipidemia, obviously PAD, ABI was found to be 0.70, TBI is 0.56, came through the ED and ultimately got a CT scan, which did reveal highly calcified high-grade stenoses throughout the SFA popliteal and tibial perineal vessels. And so we're talking about interventions here. So he was taken for an arteriogram. And I'm going to apologize. This video is actually going to start after our up and over technique. We unfortunately lost some of the video capture when we were doing this procedure. So this was an up and over access and left lower extremity arteriogram. We accessed the patient with the standard 6 French sheath, went up and over the bifurcation with an omniflex catheter, used a glide wire advantage to cannulate the SFA, put in a short 65 or a 45 centimeter 6 French sheath, and then performed an arteriogram. And at this point, my fellow here is crossing some lesions of significance in the distal SFA and popliteal. As I'd mentioned before, we did lose some of that footage, so you're not going to see the lesions in the SFA and popliteal until post-treatment. But I assure you they were quite significant. And just as a reminder, this was a first toe lesion. So here we're going to take some images, or she's going to get beyond this knee prosthesis, and we're going to take some images below the knee here.
So Mazin, when you're dealing with these heavily calcified occlusive lesions, these really complex multi-level lesions, is it your preference to treat proximal to distal? Do you cross and then you treat the tibials and go back and treat the SFA on the way out? Kind of how do you approach these cases?
Yeah, I've always been of the mindset to treat distal to proximal. I was taught that by somebody you and I both know, Frank Arco, and Frank used to treat that way. I think what that allows for is it allows you to know what your outflow is going to be before you fix the inflow vessel. I've heard arguments both ways where some folks will say, hey, you got to treat that inflow first. You got to establish, a good vessel above the lesion before you go below the knee. But it's just something by convention I've always done. What about you, Paul?
Yeah, I go distal to proximal as well, and was taught very much the same way. But if I have lesions that are multi-level but occlusive proximally, I kind of feel like now anyway that I'll try to get those out of the way first to establish some sort of inflow to make the imaging a little bit easier to see on the distal side of things. So for the most part, it's distal to proximal with some rare exception.
What about you, Leigh Ann?
Yeah, I would agree with that. I would say the only time I tend to treat the inflow first is if I'm treating just densely calcified lesions and I'm worried that the SFA lesions are impeding my ability to get maximum pushability to cross those tibial lesions. So if I need an open vessel to get my sheath all the way down, below the popliteal to maximize my ability to cross, then I think there's a case. But I would say that's a rarity. That's, the exception, not the rule.
Perfect. So here we're going to be crossing the distal popliteal into the TPT trunk. And I'm handing over the steering wheel to my fellow here, so she can get down and take some better imaging here, and I can show you guys what we ultimately found. That's an 035 Navicross catheter and an 035 glide wire advantage, and she's going to shoot an arteriogram here, and so we'll get a good look at what this patient's outflow looks like. So as you can see, the perineal artery is widely patent. The posterior tibial artery was chronically occluded, and the patient has multi-level high-grade stenoses in the anterior tibial artery proximally. Distally, the vessel was actually quite nice and did feed the dorsalis pedis with an intact pedal loop. So looking at this, how would you guys attack this particular case?
It's funny, Mazin, because I think that I would have, showed this angiogram to some people and they would have said, "What are you even treating? That looks fine. The flow's great." And I think that this really highlights the underdiagnosis that an angiogram does. I think that we need to use IVUS. We need to use, if you have a pre-op CTA, because this might look like there's inline flow via that AT, but you and I both know that if you IVUS that, you can tell where those spots are where it's going to look, 80, 90% stenotic, even though you've got a flow lumen, because I think we have to be mindful that we're just looking at a 2D image here. We're not looking at a 3D image. And so, I think in these heavily calcified lesions, angiography is not the best to determine degree of stenosis. And I think you pointed that out earlier.
Absolutely.
So my approach to this has shifted quite a bit. And so when I'd say a year and a half ago, I'd say, yeah, E8 for this, absolutely. But now I look at that and I'd say I'd use Javelin for that, no question. And I just have kind of shifted that Javelin is no longer for me like a last ditch Hail Mary kind of thing, as kind of we thought the indication for it was. But now it's for me an everyday below the knee tool. And so I look at that and I'd say, I'm going to run it down the AT and I'm going to treat that. And then whatever left, I'm going to treat the TP trunk and get the whatever perineal disease I want to as well. And I find that that's the most efficient approach for me to deliver IVL and then follow that up with an angioplasty.
And I would say
Absolutely.
I'm probably going to use E8 and I'm going to E8 almost that entire proximal 2/3 of the AT. But I mean, no, and we're kind of laughing, but I think like these are tools in your toolbox and you have like you do you've got to do what works best and the technology that you're comfortable with to optimize your patient outcomes. And I think these all play a role.
Absolutely. So what we decided to do is exactly what Leigh Ann described here. We went ahead and crossed this lesion with an 014 wire, and we'll show that here in just a second. Sorry, quite a bit of movement. This is the distal arteriogram. Just want to show you guys that the distal outflow was nice and intact. So we didn't have to go down deep into the base of the foot here. And there you can see a nice intact dorsalis pedis. Pedal arch was actually intact as well. So just moving a little bit along here. Let's see if I can This is us again, once again, utilizing an 035 Navicross catheter. We did reduce our wire size for the crossing down to an 014 catheter, or excuse me, 014 wire. But to your point, Dr. Foley, I have routinely used 035 wires and catheters below the knee and have had great success in doing so, but it's a little taboo. Can you talk a little bit about that?
Yeah, I don't know if it's because I finished training in 2012 and I kind of had this meatball approach of like everything's like an 035. I also trained at a place that was like heavy in terms of aortic interventions, and so everything was an 035 platform. And my understanding and technique for dealing with lower extremity disease, and certainly disease below the knee, was something I learned and adopted well into my career and post training. So a lot of what I learned, I just sort of picked up from observing other people, and getting feedback and input from interventional cardiologists who are always on an 014 platform. And so that's how I kind of adopted it. And I think it's been very versatile in terms of the availability of catheter and wire options, and really setting yourself up for success. And so that's kind of what I do now.
Yeah. So we did have a preoperative CT scan, and we're able to assess the size of the anterior tibial arteries, roughly 4 millimeters in greatest diameter, a little bit more proximal. It did measure about 4.3, 4.4. So we selected a 4.0 E8 balloon catheter to treat that anterior tibial artery. One of the questions we always get is, this is not a particularly long lesion. It's not going to take all of those pulses to treat the entire anterior tibial artery. What's your energy delivery strategy here? And I can tell you what we did.
My energy delivery strategy would be all of them. Yeah, all 400 pulses, and just
bought it, you use it.
Yeah, same here. If they give you 400, I use 400. They give me 300, I'm using 300. I just expense the whole thing. You're not going to create damage to the vessel by using more pulses. And so I always deliver the full spectrum. I'm glad to see you guys do that as well.
Can I ask your inflation strategy? Like when you're putting this down, and I know it's 2 atmospheres or 4 atmospheres, but do you just kind of eyeball it as well? I mean, I've gone also to just kind of making sure I fill the space too. And if that's at 1 atmosphere, or just to start with and get your first round of pulses, what do you do?
Yeah, I do exactly that. So I'm not inflating to nominal by any means. If I, at 1 atmosphere, get apposition of the balloon to the lesion, then that's plenty of inflation for me. Sometimes after the first set of pulse delivery, I will go up to at least 4 atmospheres of pressure, just to ensure that we get full contact of the balloon, to the vessel wall. But I'm with you. I don't use this as an angioplasty balloon. It's primarily for energy delivery, and so everything is low pressure. In this section, we did treat the distal popliteal and the distal SFA as well. I know I didn't show you guys those images. We lost them, unfortunately, but there were some significant 80% stenoses in the popliteal and in the distal SFA. So we're utilizing that same 4 millimeter balloon in this location.
I think that's a really good example too of how this balloon catheter can really be used to treat long length lesions, but if you size it appropriately, you kind of hit a sweet spot. You can really get across different vessel beds as well. And then if you had multiple tibial beds that you had to treat, you could distribute those 400 pulses across that. So I think it's a nice example of how you can do that here. Again, I sound like a broken record. I've gotten into these, distal popliteal lesions entering into the TP trunk or entering into the proximal tibial vessel. I think that's also another great use of Javelin as well. And we're all in sort of the same mode where we're trying to be conscious of how many catheters we open, how many different devices we utilize. And it's really nice to be able to, in this case, use one balloon catheter to treat an anterior tibial and popliteal lesions. And I think the same way in terms of the ability of Javelin to treat and deliver pulses into a pop and then extend down into a tibial. Same ultimate goal, it's just a different kind of method to get there.
Yeah, to your point, that's one of the beauties of E8 is our ability to treat multi-level disease with one balloon catheter. I mean, you can treat upwards of 200, millimeters of vessel without much difficulty, and still be able to deliver an adequate amount of energy to all of these levels: SFA, popliteal, and anterior tibial artery. So once we completed our balloon angioplasty, or excuse me, our energy delivery here, we did decide to go ahead and treat not only the anterior tibial artery, but also the popliteal and SFA with a series of DCBs. We did select a 4 mm DCB for the anterior tibial artery, which we'll show here in just a second, and then selected a larger balloon for the popliteal and SFA. But as you can see there, the excellent result in that AT. So now we're delivering the drug-coated balloon, and we're going to treat the AT with that as well. Is it pretty standard for you guys to use a drug-coated balloon after balloon angioplasty if it's applicable?
Yeah, I would say that's pretty routine for me. I'm still of the camp that I really don't like to leave nitinol or metal behind if I don't have to. And so if it looks good on IVUS, I'm going to routinely, IVL and DCB if it's, if it's indicated and appropriate.
Yep, agreed, same. What I think is great here too is because you had a nice idea about sizing, you were able to do that in this particular case, right? Whereas, if you hadn't, you may not have put a 4 mm balloon down there.
Yeah, I probably would have undersized. You're right. Absolutely.
Oh man, I can't, I think I used to use like 2.5 balloons routinely in the tibial vessels before I started sizing, and now I'm just like shocked at how undersized I was delivering my devices. And it probably contributed a lot to early patency loss. I mean, we know that in the literature. So, I think the point that we're making through this whole webinar of sizing appropriately, maximizing the size of your balloons is so critical to long-term primary patency.
Great points. Absolutely. So we're going to push ahead just a little bit, and we'll shoot our final angiogram here and give you guys an idea of what kind of result we ended up getting.
And I want everybody to pay attention to this final angiogram, because if you thought that anterior tibial looked okay at the first shot, what you see now is pretty remarkable in terms of luminal gain, I think. The suspense is killing me.
She's coming. She's coming. Don't worry. So I think a really good result here. The SFA and popliteal are now widely patent. There's almost zero residual stenosis. I did subselect out the anterior tibial artery again with a separate catheter to take a more distal arteriogram. But just wanted to highlight here how well this fills. Those multifocal lesions are now essentially gone, no residual stenosis of any kind. And you've now turned that into a healthy vessel with good pulsatility. And luckily, I saw this patient back in the clinic on Monday. This was literally done 3 weeks ago, and his anterior or his first toe ulcer has completely healed.
Yeah, that's great.
That's really remarkable. I mean, I'm still of the thought that a single segment great saphenous bypass is such a great operation, but you're giving this patient a normal artery. I mean, you are restoring normal anatomic pulsatile flow through the anterior tibial artery. And so, I think pre-IVL and pre all of these tools that we had, you weren't getting that sort of inflow into the foot. You weren't getting healing at 3 weeks. You were getting healing at 6, 8, 12 weeks. So it's pretty remarkable what we've been able to accomplish now. And that's just an incredible result and really good for the patient.
Yeah. It's outstanding.
All right. Well, we've got 3 more minutes for discussion. So, if anybody has any burning questions, feel free now to put them into the chat. If not, I, really want to thank my colleagues, Dr. Foley and Dr. Foteh, for joining me tonight. I think this has really been such an amazing educational discussion. And I love that we got to talk about both Javelin and E8 and kind of banter back and forth about the applicability of both of them, because I think you can see that while all three of us might do things a little bit differently, we all kind of have the same tools in our toolbox and use them complementary to afford the patient the best result. I don't know if you guys have any closing comments or any other last minute thoughts.
I think this was a great example of how these two technologies can be used in conjunction with each other for various types of pathologies. And although they have a little bit of a different mechanism of action, they can be complementary. So remember them when you're treating your next set of patients.
Yeah, I'd echo all of that. These are very difficult cases. It's a very challenging patient population. Anything that we can utilize to achieve a successful endovascular outcome, especially in these very difficult calcified lesions, we should take advantage of. And I think these two cases really highlight the ability to do that.
And the last thought I just want to leave with everyone is that, Shockwave has such a great armamentarium of clinicals and reps and support for your cases that when you start to bring Javelin into your portfolio, bring them into the OR. The learning curve is a little steep, but once you get a rhythm going, it's really nice and smooth and it goes well. But bring them into the room, have them show your team how to use it, make sure everybody's comfortable with it, because it is a new technology. It's a new way to treat the vessel. It's a new way of thinking about it away from balloon-based therapies. And so with that, I'm going to leave you. Please, if you're hanging out and you got your phone in your hand, go ahead and scan this QR code. This is just a little post-event survey. Feel free to tell everybody how great Dr. Foteh and Dr. Foley are. And answer choices are displayed from strongly agree to strongly disagree. So with that, I want to really thank everybody for spending the last hour of their evening. I know it's really late for everyone on the East Coast, and for those on the West Coast, it's getting to be dinner time. So we'll let everybody have an enjoyable evening, and thanks for joining us, and have a great night.
Good night, guys.
Thank you.